Good, oh, good afternoon, ladies and gentlemen. Welcome to this session P, which is going to show a televised live case from the National University Hospital by Dr. Adrian Low. Now, today we are focusing on a rather unusual case, which is not the usual balloon and stenting sort of procedures in complicated cases. But Dr. Adrian Low is going to show us the more quantitative and definitive way of diagnosing microcirculatory problems. As you know, there have been many cases of angina, atypical angina, or angina with normal coronary arteries in the past, which we have had difficulty actually pinpointing what is the problem, and sometimes labeled as a vasospastic angina or syndrome X or microcirculatory problems. Now, today we will be treated to a new novel way of having a special investigatory tool to diagnose more accurately what is microcirculatory problems. And without further ado, let me just introduce our speakers and panel today. Dr. Mark Chan from NUS, also co-chairing, and our panel are very distinguished, Dr. Sydney Low from Sydney, Dr. Liu Bunhua from Changi Hospital, Singapore, Dr. Anak Kanalop, I think from Malaysia, yeah? Dr. Ong Tieng Kiam from Malaysia, Dr. Fauzi Yahya from Indonesia, and Dr. Alfred Mandos from Philippines. So without further ado, I'll pass on to the live transmission from NUH, Professor Adrian Low.
Sure. Hello. Hi. Thank you, everyone, and thanks, Richard, for the kind introduction. So before I start, I would like to just introduce my team. I have with me today Dr. Khoo Che Yang. Yeah. We have our nurse, Kui Fong, our nurse manager, and there's Alpun in the background, and our radiographers, Tian Yong, as well as Darren, our technician, who will be assisting in this procedure. So this case that we're going to be sharing today, next slide, please. Can we go to the slides? Yeah.
Yes.
Don't see the slides yet.
Hey, Dr. Adrian, you go ahead first because they didn't allow us to share the slides.
Okay. Basically, as a prelude to the case that we're going to be doing today, this is a 45-year-old woman who has been troubled by complaints of chest pain since 2019. In fact, she has actually consulted two independent cardiologists outside and had an invasive coronary angiogram done at an outside institution in March last year. So I'm going to be sharing the angiogram later. Now, subsequent to the coronary angiogram, because of persistent symptoms, she actually underwent stress testing and also had echocardiography, and they were all within, at least nothing definitive was gained from the investigations. And because of persistent symptoms that had some features suggestive of angina, her second cardiologist referred her to us for further evaluation. I think I can see my slides now. Let's go to the okay, so basically, as just to refresh everyone on the CorMicA trial, because this would really form the basis of what we're going to be doing today. The CorMicA trial was the first study that established the role of functional testing in managing patients who have ischemia with normal coronary arteries. So this was a blinded randomized controlled trial conducted in UK and published some years back. And basically, there were patients who had mild to moderate angina as defined on SAQ scores. And these patients were randomized to a function-guided management versus the conventional treatment. So the primary endpoint is not your typical major adverse cardiac events, but rather a change in that perception of angina severity at 6 months and subsequently as a secondary endpoint at 1 year follow-up. In the initial study, they identified 4 endotypes. One was patients who had purely microvascular angina, patients who had vasospastic angina, patients who had both microvascular as well as vasospastic angina, as well as clearly normal patients, which constituted about 11% of patients. Now, by having a clearly defined endotype, they could adjust the treatment accordingly. And on follow-up, the patients who were treated with this approach actually had symptomatic improvement. So that's what we plan to do today. Our objective in this session is to demonstrate the whole range of functional testing in a patient with presumed non-obstructive coronary artery disease. And we're going to show you how the Coroventis system allows us to evaluate the coronaries. And we'll also be doing a coronary provocation study, specifically looking at coronary artery spasm. Because if you recall, one of the endotype is vasospastic angina. So I have my patient with me today, and we repeated some of the angiogram. Now, before I show you what we did today, if I might show you the slides. Can I have the slides, please? This is the CorMicA trial protocol, which we are going to be following quite closely. You can see from the schema that we start off first with functional evaluation, looking for the coronary microvascular dysfunction using a conventional methods of nitroglycerin and IV adenosine. This is then followed by incremental dosing of acetylcholine, evaluating for ECG changes, symptoms, with which increased dose of acetylcholine. In our institution, our protocol is similar with some caveats. Next slide, please. You can see that where we differ is that we also do use papaverine for hyperemia in our institution, but for today's case, I've decided to use IV adenosine so that it's less stressful for everyone. Now, we also differ in the dose of intracoronary acetylcholine. I had not actually adopted the CorMicA trial protocol of acetylcholine because the maximum dosing is 100 micrograms, and when we actually tried diluting it, they didn't actually have a clear zero dilution protocol. So what I've done is to adopt the German protocol. Andrew Ong is well published in coronary artery spasm, and he has a very nice protocol on zero dilutions. And this allows us to go from 2 to 200 micrograms of intracoronary acetylcholine, as well as looking at the right coronary artery if necessary. And otherwise, the protocol is similar to the CorMicA trial. Next slide, please. So I've alluded to earlier to our patient today. So apart from a history of this lipidemia for which she is on statin and persistent symptoms with atypical features, she is otherwise well. Next picture, please. Next slide. Can we advance the slide, please? Thank you. So this is a montage of a coronary angiogram that was done at an outside facility on 5th of March last year. And you can see that it's essentially normal. So next slide, please. Despite this, because of persistent symptoms, further testing was done by the outside facility, including a treadmill stress test. And I've actually reproduced in verbatim the conclusion by the attending cardiologist. So essentially reached stage 3, no definite ST depression, some mild T inversions, no provoked angina, echo was normal. And because she was still very troubled, she consulted another cardiologist who had some revision to her medicines and streamlined it to just a statin as well as nitrate patch. Now, in preparation for this study today, she was advised to stop the nitrate for 48 hours prior. So she came in today, and we've decided to adopt a femoral approach because of apparent radial artery spasm during her last procedure. So we wanted to avoid that. So what you see here is that we have already inserted a 6 French slender sheath using ultrasound guidance to the right common femoral artery. Now, if I might show you today's angiogram, specifically the right coronary artery, can we show the angiogram, please? The next picture. Next, both plane A and plane B. Now, you can see that, interestingly, using just a 4 French diagnostic catheter, she already has what appears to be spasm of the ostium of the right coronary artery. Now, one may argue that possibly this could be catheter-induced. Yeah, but
Adrian, the slides are not
and we are
advancing.
now at the left system. Can we
see the
show the
Adrian,
left
we're
system,
not seeing the
please?
angiogram.
Pardon?
See the right, please.
Yep.
We don't see the angio.
Oh, you
Yeah, the slides
you
are
can't
not.
see the
Okay,
angiogram?
that's great.
Yeah. Okay. Now
You
yes.
can see now.
no, that's not. Can you stop the? This is not this slide. Can you stop the slide, please? Can you come live to my? Yep. Come back to the screen. Yes. Okay. Come back to the cath lab. Can you show the coronary angiogram done today? I don't see it.
Where is the spasm on the right coronary artery, Adrian?
Yeah, I would like to show you if I can.
Okay.
The technical team.
Can we go?
Can you go back to the prior angiogram, please?
But it's also cut off.
Can you show us, please? I think it's not showing very well.
Then Tan Yong, maybe we go back.
Back one picture?
Back one picture.
Yeah,
go
that's
back.
right. Okay,
Yeah.
good.
But it's cut off.
Can we see both the plane A and plane B? I see only the bottom part of the right coronary artery, which unfortunately, oh, okay, that's better. Okay, can you see this is plane A? So this
Yes.
is a repeat angiogram using a 4 French diagnostic catheter.
Hmm.
So this this apparent stenosis was not seen in the prior angiogram, and we suspect it's just all catheter related. So before we decide to come back to look at the right, we decided to have a look at the left first. Can we show you the left system today? Yes, so this is the RO caudal view. So the left artery, you can see is quite normal from this projection. I'm not sure if you can see plane B as well. Can you? Can you see both plane A and plane B, or you can only see plane A?
Plane
A only.
So can you see plane A?
Next picture. Okay, good. This plane B. And then this is the spider projection. And next picture. And this is the RO cranial. Can you go back to plane A now? I think whoever's managing this is getting confused, right? With me going plane A and plane B.
Yeah.
Maybe just to avoid confusion, I should just stick with plane A, if that helps everyone.
Yes.
Okay, so this is where we are today. So
Sorry, Adrian.
I plan
Sorry,
to
may I
do-
stop you? Adrian,
Yes, Richard.
the right, did you try a bit of nitro to see whether the repeat angio will have abolished the
Not just
spasm?
yet. Not
Okay.
just yet, yeah. So before we do that, I thought we'll just try and stick to the protocol as much as possible, which is to advance the pressure wire into the LED, do a full functional evaluation, do a full provocation test in the left system, and if that's negative, then I go to the right. That's my intent.
Sure.
So if there are no further questions, I'm going to now advance the pressure wire into the LED. So we have already flushed the wire.
So Adrian, do you think the LED's got intramyocardial segment in the middle portion of it?
I don't see actually definite contraction or systolic constriction there. It might be a band there, so I'm not too convinced. But in any case, I think it will be interesting to see what the pressure indices show. So I know in the audience there is some who are just starting out on doing invasive evaluation and some very well experienced operators. So the experienced operators, just bear with me because I'm going to just try and explain some of the things that we do for those who are just starting out, so that they can understand what we actually need to do to ensure that we have accurate pressure measurements. So the first thing that we do is to advance the wire, the radio-opaque segment just outside of the catheter, and make sure you remove your wire introducer. I'm not sure if you can see my hands before you equalize. Okay, so I tighten this, and then what I usually like to do is also to just flush the system during this phase here. So Tianyong, can you just start that, please? Yeah. So flushing actually does clear out some of the micro bubbles, which can result in drift. So I find that this actually helps in minimizing drift. And we get the technician to just equalize now. Can you see the Coroventis screen?
Yes.
Okay, so we're just equalizing now. And ideally, I would like to wait for a minute, but I know that interventional cardiologists are not exactly the most patient of people, so we're going to wait at least 30 seconds just to make sure that we have a stable signal. Because if you don't have a stable signal, then you're going to suspect your measurements thereafter. Do we have any questions at the moment from the panel before while we're waiting?
Hey, hi, Adrian. This is Benoit. How far in advance do you ask?
Sorry, I can't hear you.
How far in advance do you?
Hear you.
Can you hear me now?
Yes, I can hear you now.
Okay, so how far in advance do you get the patient to stop the anti-anginal?
I asked her to stop for 48 hours at least. Now, I know this is challenging sometimes because sometimes you have patients who are so symptomatic, they're not even willing to. So I think you just have to bear in mind that the longer that they're on anti-anginals, your sensitivity of your test might decrease, especially with regards to vasospastic studies. But I think this is where you want to try and get them to be off the drugs as much as possible. Yeah, so you have to come up with a balance, what you think is a reasonable duration that they offer and which they are able to tolerate. In her case, she's only on a patch nitrate. So I've asked her to stop it for the last 2 days. So in theory, today is the third day that she's off the patch.
Adrian.
Okay, yes.
Thanks very much for showing this interesting case for us. One question I'd like to ask is, eventually when you're going to test the physiology indices, how far down are you going to pass the transducer down? To the middle third of the artery or all the way down to the distal third? I mean, in usual standard practice, we assess physiology, we pass it down, borderline lesion, right? But
so the good question is, Jiamei, I would actually advance it all the way down to the distal third as per routine practice. So that's what I'm going to do now. So I've reinserted the wire introducer. I'm going to try and advance the wire down into, I might be in a low branch. Can we look a low test and see where we are? Good. Yeah, that looks like a branch, the diagonal branch.
Dr. Adrian, would you evaluate all the vessels? Yeah. Would you evaluate all the vessels or just concentrate the vessel that you suspect is the cause of angina?
In the CorMicA trial, they focus only on the LED. And unless there's very good reason to evaluate the other coronaries, I will just stick with the LED.
Maybe a branch.
Okay. It seems to me that the RCA is a spasm, right? It's moderate.
Osteo-RCA, that's right. There's a spasm. But as per the CorMicA protocol, the majority of patients had evaluation of the LAD. So I'm going to just see what the LAD shows first. If the LAD doesn't show anything, then I might actually move over and do the RCA. Okay, so we're down to where we conventionally would place the pressure wire into the distal third of the LAD. Now I'm going to just share with you what I usually would do. So I would do a RAS PDPA because I know that there's a lot of interest in RAS as well as hyperemic indices. And I think these are good opportunities for an appreciation of what actually is a better index. So let's look and see. So this REST index is now 0.93, a PDPA of 75/80. Can we record that, please? Okay, stop recording. Okay, so the REST index 0.92 at the lowest, 72/78, which is normal. Let's go and do an RFR. So this is the proprietary REST index. Almost always is lower than the REST PDPA, 0.86. Now this is interesting. So your RFR actually suggests that the LED is abnormal.
Ooh.
RFI is 0.86. Okay, so what I'm going to do now is I'm going to do the usual CFR hyperemic evaluation. So
could the abnormal RFI be because of that intramyocardial segment? That if you pull the transducer proximal to that, it might be normal.
Yeah. So yeah, let's see what it shows. Okay, so I have this 3 mL syringe here. I'm going to do the thermal dilution study now. So basically, you do 3 injections. Okay, Laura. Good. Start that for me, Tianyong. So that's the first bolus. I'm not sure whether you can see the screen there. Slow injection, 0.84. I'm going to just inject again. So this is Jacquin's left catheter. I wasn't expecting to do anything. Yep, 1.11. So it takes about 1.11 seconds for that saline bolus to reach the thermistor. I'm going to just repeat another one. Let's see what it shows. Probably repeating a 1.11. Yep, we're going to just repeat a 1.11. Yep. Okay, I think they're all quite reasonable. So I'm going to just take this. I'm going to now proceed to induce hyperemia. Yeah, can we start the IV adenosine? Just push your 4 mL. Now, as per usual protocol, I will just give 200 mics of GTN. And we are starting the IV adenosine infusion now. You push 4 mL ready? Okay, tell me when 4 mL are up. And then once the 4 mL are up, we can start the infusion. Okay, just start the infusion. Okay, so can we start the timer, please? Good. So during this period of the IV adenosine infusion, we look at the parameters, the hemodynamics closely, and you can see that the PDPA is also being recorded. So you will see that it will actually fluctuate once hyperemia occurs. You can see the PDPA ratio dropping usually. So 30 seconds into infusion. Now, so that's the other thing for those of you who are using IV adenosine infusion. You got to make sure that you actually wait for the time it takes for the dead space. You see that the PDPA changes now, okay? So usually I like to keep that infusing at least about a minute. So we're getting to a minute there. Can we start the injection? Good. First bolus. You see, it now takes just 0.48 seconds to reach for the saline bolus. Get ready to stop.
Phone standby.
Oh, okay, good. Click End. And I'd like you to just go to FFR. Okay, so we're now going to just do a pullback. So I usually like to do a pullback. Recording? The reason why I want to do a pullback is for 2 reasons. One is to see if there is a specific lesion with a distinct gradient. And the second is also to verify that there has not been any drift. Good, stop. Start that for me, please. So there's no drift here. So I'm quite confident of my measurements. So let's just look at the parameters. You can stop the infusion. Yep. So you can see from the parameters here that with the exception of an RFR that was abnormal, your REST index PDPA was 0.92 if I recall. Again, normal. Your FFR is about 0.8, 0.83. Your coronary flow reserve, your CFR, is above 2, is 2.6. Your RMR is a little bit on the high side, 29. Corrected is 27. There's this new index called RRR. You can see there, right, the bottom there. Now, no one really knows what a normal RRR is, but in general, from the literature published to date, I'll say that consistently above 2.5 is generally what's considered to be normal. Now, this index is like a surrogate of the microcirculation. So it's like the equivalent of CFR for microcirculation. Evaluates how the microcirculation responds to hyperemic index. So the higher it is, the more likely that it will respond to hyperemic stimulus. So what we can conclude so far from the functional study is that the patient does not have functionally significant or hemodynamically significant coronary artery disease as per your usual FFR definitions, but the elevated IMR does suggest that she has microvascular dysfunction. So most times you can just stop here, but in her case, we're going to just persist further to see whether she might also have vasospastic angina in addition to microvascular dysfunction. Because if you recall, a cohort of the patients in the CorMicA trial actually had both microvascular dysfunction as well as vasospastic angina. So what I'm going to do now is I usually like to send the wire down back into the LED. I know not everyone does it, and I'll tell you why I like to send this down. One reason for sending the wire back down into the LED is that it gives me at least a surrogate measure of how much spasm there is, because when you get a spasm, you're going to see the PDPA ratio changes. It actually reduces. It's not quite a FFR, but it does provide an assessment of what is the spasm in your epicardial coronary. Okay, so I'm almost down there. Just add a bit more. Just give a little test on me, please. Okay, I think we're good enough. I'm not going to send it further down. Okay, so we have a baseline coronary angiogram. So we have a protocol that actually allows us to perform serial dilutions of the acetylcholine. So the nurses had earlier spent a lot of time diluting it. So as per our protocol, we're going to start first with 2 micrograms of acetylcholine. Now, before we do that, we're going to record the 12th ECG. So we set it up that, much like the EP boys, you can see the 12th ECG tracings there. So what we're going to be looking for is to see whether the patient has provoked angina, whether there are ST changes when we give the acetylcholine. Okay, so I'm going to just put the contrast syringe aside. This is the 2 micrograms. You've got a flush.
Yeah.
So I can just, let's go to RO caudal. Now, in the CorMicA trial, they usually would take an angiogram in the RO caudal projection, and with the guide catheter in the left. One advantage of doing that is you're basically looking at 2 arteries. You're looking at the LAD as well as the circumflex with the RO caudal projection. So I'm going to just take one baseline picture here so that we can compare later. We can just go to single plane. Thank you, because they can't see anyway, and you get confused which one is plane A and B. Okay, so this is the baseline, and you can look at the ECG. This is the baseline ECG. We can just record this, Darren, as baseline. I'm going to just give my 2 mics of acetylcholine. We stand by atropine. Yeah, so now, for those of you who have not given acetylcholine, it can cause bradycardia. So it's easily reversed with intracoronary GTN. I can just stock up again on my GTN. Or if the patient is profoundly bradycardic, you can actually give atropine. So this is the acetylcholine, and you just administer it over like a 20 seconds, and so you can see that my rest PDPA is 0.92. If there's any significant spasm, you're going to see the ratio fall. So that's one advantage of having a wire there. Okay, I'm just administering. Most patients do not have any response at this dose of acetylcholine. It's just 2 micrograms. Okay, can we record the ECG, please? So then after we have administered the acetylcholine, we do a 12-lead ECG. Good. And I'm going to do a angiogram. You see that the PDPA is pretty much the same, so you expect that there shouldn't be any spasm, which is what we expect. So this being normal, we're going to go now to the next dose of acetylcholine. So this is 20 micrograms. So this is 10 times more than what we had. Again, most patients do not respond to 20. It's usually at the 100 or 200 that you start seeing some response. Let's just see. I'm just making sure my guy is all right. So again, I'm going to just administer the acetylcholine slowly over about 20 seconds. I don't see any ECG changes yet.
So if there are no changes, how high would you go with the acetylcholine?
The highest dose is 200. So we're at 20 now. The next dose will be 100. So this is just flushing in. I don't see anything at all. Okay, can we just record the 12-lead ECG, please? I'm going to do an angiogram now. So again, you see that the PDPA maybe looks about the same to me, 0.84. Picture. No spasm that I can see. Still pretty much look the same. Okay, we're going to now move on to the next higher dose, which is 100 micrograms of acetylcholine. So she's tolerating it quite well. She doesn't even have much bradycardia.
Yeah. So in fact, if you give very slowly graduated doses, you think the arteries might get sort of used to it or immune, rather than if you give 120, 150, then 200?
I'm not sure about getting tolerance, yeah, but the protocol actually, calls for incremental dose, so I'm not sure that you're going to get tolerance with this bolus doses at this during the study.
There's some brady coming.
Yep, that's right. You can see that the T wave are kind of like flipped too. And you look at the rest PDPA, the ratio is 0.81. So that's a good surrogate that you're probably going to see some spasm. Now you see it dropped to 0.73. I'm going to take a picture now. I expect that we're going to see some spasm. See that?
Yeah.
So the LED has documented spasm. So you can see the ratio of 0.66, 0.65. I think we're quite satisfied that she also has vasospastic angina. Now, I think she is quite well. Are you feeling some discomfort? Yes, so that's because your arteries are quite narrow now. I'm going to reverse it. You should feel better. Just bear with me. So that discomfort just woke her up. I'm going to give some nitrates now, GTN. Can we start that, please? So you can just see that the ratio should actually normalize. Sometimes I need to give a bit more. Can I have more GTN? Yeah.
Normalizing.
Yep, good.
Dr. Lo,
You should be feeling better. Are you feeling better? Good. The patient is also feeling better. So it's back to 0.86. I'm going to take a picture now just to document that the coronaries have normalized.
Dr. Lo, there's a question from the audience.
Okay, you can see that the LED is now back to normal. So I think she clearly has vasospastic angina. And I think today we have demonstrated that she has both microvascular dysfunction as well as vasospastic angina. I don't see a need for me to give a higher dose of acetylcholine, given that we already have a positive test with 100 mics of acetylcholine. And I don't see the need for me to also evaluate the RCA, because if I'm going to be treating her for possible vasospastic angina, it's going to manage the RCA as well. So there's no need to put her through another additional test. I pretty much am done for today. I have my diagnosis, and I know how I'm going to treat her. Does the panel have anything to add? Someone mentioned that the audience has some questions.
Yes, there's a question from the audience, from Dr. Jafari. Can you please reiterate, was the injection for the thermal dilution made into the guider? And how many cc were injected each time?
Okay. So it's administered intracoronary. You can see that my guide catheter is at the ostium of the left coronary artery. So this acetylcholine is basically administered directly into the coronary. So I basically would just make up the volume to about 10 mL so that it's easier to administer over about 20-second period. Then I just flush it later with saline. And I look for symptoms, ECG changes. Does that answer the question?
Yes. There's another question. I guess the topic is very interesting, and the people are quite into the case. So, how long does it take for the acetylcholine-induced spasm to resolve spontaneously if no GTN was given?
If no GTN, I think it's a couple of minutes. But usually when you see that sort of marked changes in the patient symptomatic, you wouldn't want to wait too long. You're going to get a very painful patient on table. So I almost always reverse it after I've established the diagnosis. I don't see a need for it to wear out. It's going to take a couple of minutes, and there's no need to, because what you want is to just try and provoke the spasm, establish a diagnosis, and move on.
Okay. And a follow-up question was, are there any contraindication to performing this protocol? Example is a poor LV function.
Severe LV systolic dysfunction. I've never done it in a patient so far with severe LV systolic dysfunction, and usually they're unlikely to have a concerns with vasospasm or coronary artery disease. So no, I have not actually, in my experience, done it in someone with severe LV dysfunction. But I would guess that some of the medicines that you use, like GTN, could potentially lower the blood pressure. So you just need to be more careful. But I'm not aware that acetylcholine per se is going to be detrimental, especially since the effect is quite transient. So if you can just look at the RAS PDPA now, it's actually much better. It's 0.9495 here. So you see, it just reverses very easily with nitrates. It's only in very rare instances that you need to give your atropine, which we didn't even have to in this case here.
So originally, correct me if I'm wrong, Adrian, because the original studies show that if the arteries are very healthy, giving acetylcholine actually makes it vasodilate. And if the arteries are prone to spasm, then actually giving that will actually make it constrict.
Yes, absolutely right. So it's looking at the endothelial function, acetylcholine. So her arteries are not healthy, at least endothelium.
So can I ask about cardiac MRI? Is it useful in the pre-workup assessment of these people? And of course, CT coronary angiography.
MRI.
If you start,
I'm sorry? I
CT coronary angiography.
Yes.
Regarding CT coronary angiogram and MRI,
the CT coronary angiogram just provides an evaluation of the anatomy. So the MRI, it's one of the issues is its availability, and I think in theory, looking at perfusion, probably your PET imaging would be better for that rather than MRI.
Yeah, I'm kind of alluding to the fact that you start off at a state of normal coronary arteries. And the CT may suggest the arteries look pretty good, but because you do an invasive assessment, it's incredibly specific and sensitive to the diagnosis of epicardial coronary ischemia. And so that, and therefore you check that, you check that very accurately with a pullback, etc., looking for the FFR during the test. And also a diastolic index as well, so that that was a little bit negative there, but that was probably explained by the fact that there was a microvascular disease as well in that situation, an resting condition.
Yeah. Yeah, I think there's still a lot of things that we don't quite understand yet. But I think as this is the beauty of this functional evaluation is that it opens up a whole suite of things that you can do and potentially treat these patients who previously have very much been dismissed. So now that we know what she has, I think it's good that we can be more focused in managing her.
Okay, I've spoken to the Dr. Ford, who's the first author on the paper of CorMicA. And in some of the patients, there was a good correlation with people with muscle bridges. And in some of their patients, they've titrated diltiazem to well over 500 milligrams a day. So can I ask you about the medical therapy, maybe for this lady? What are the options?
Okay, so she's currently not on any calcium channel blocker. So I'm going to just start on some calcium channel blocker and increase as tolerated. Yeah, and we know that for patients with coronary artery spasm, they do require high doses of diltiazem. So not your conventional 120 milligrams. So yep, I'm going to just try and increase as much as I can, as much as her blood pressure tolerates too.
I think at 500, do you think there'll be an ankle edema very commonly at that dose?
Yeah, especially for relatively young women. Yeah, don't know. So as much as tolerated.
Yeah, I haven't got anyone up to 500.
Not myself either.
Adrian, let's ask the other panelists any other points on this very interesting case. Siu Boon, have you any case, any questions, any points? Haven't you? Boon Hua, are you still there?
Yes. Oh, just one question. I mean, if you have gone on to require to do the RCA, would you routinely buy a pacing backup?
No, I don't. Yeah, because the effect of acetylcholine is usually quite transient and you can easily reverse it. So I don't like to just stick in another tube in her. So I don't.
Actually, the right coronary artery, Adrian, seems to be the one that is more prone to spasm in the cases that we do. Very often a little irritation of the ostia and the spasm, but they are easily relieved. So in a way, I'm a bit surprised that you didn't want to show the right side, but show the LAD, which is of course more important artery. Now to ask you, you showed 2 points. One is that there is spasm. And then secondly is that there is also microcirculatory problem. How do you distinguish? If there are 2 points, I think the treatment is the same. If there's only one problem, would the treatment be different in any way or still the same sort of treatment regime? Now, is
I think that those are good points, Richard. I think if the patient has documented coronary artery spasm, my inclination is not to use a beta blocker. If the patient has only microvascular dysfunction, yes, I would actually use a beta blocker. In her case, because of concomitant vasospastic angina, I would not actually use a beta blocker in her. I would just go with diltiazem. And the newer drugs like ranolazine would be something to consider in her case. And also the good old Vastarel is common in newer iterations now.
Yes. Dr. TK, you have any other points? TK Ong?
No, I'm just wondering because the microvascular disease and the vasospastic angina both do respond to calcium channel blockers. whether for those laboratories which don't routinely do this acetylcholine challenge test, a trial or treatment with a calcium channel blocker can be considered as an option.
Yes.
One more thing, Adrian, I want to ask you for simple cardiologists. Do you think the blushing sort of grading correlate in any way with the microvascular problems at all? Just a blushing.
I would.
Grading.
Yes, certainly. I think you brought up a very good point. You know, during my early days of training, we were taught to look at the blush as a surrogate of the microcirculation. But unfortunately, I think there's very little emphasis on it now. And now we use the more objective measures, like passing a wire down and measuring the IMR, the CFR. But you're right, Richard, previously, especially after primary angioplasty, one way to evaluate for how much of the microcirculation was damaged is to look for the blush or absence of blush following coronary angioplasty in the primary PCI setting. And that was what the initial trials did before we have a lot more technology available now that allow a more precise assessment of the microcirculation.
So Adrian, in Australia, we are 3 minutes away from the next session. So maybe we just allow for one more question. Then Adrian, can I just trouble you to give us a summary of the functional evaluation of causes of angina in patients with non-obstructive coronary artery disease? I mean, one more question, anyone?
Yes, Mark, given the fact that 50% of patients admitted to cath lab has no obstruction coronary artery disease, would you do routinely this kind of procedure, or just give them beta blocker first, because mostly the patient have a microvascular dysfunction, and then if not work, we can give calcium antagonist, because performing this kind, which are very beautiful demonstrated by Dr. Adrian, would might be it's not can translate to other center as done by the experienced operator.
Yeah, good point, Fauzi. I think what you say is very true. On a practical level, I don't do it routinely for every patient. So it's only when the patient has persistent recurrent symptoms and there are concerns, do I actually do this, especially after they fail an initial trial of empiric medical therapy. So you're absolutely right. It does take up a bit of time, and I don't do this routinely for every patient. But this patient has been symptomatic since 2019, and as I've shared earlier from her history, she has had significant investigations done, still very symptomatic, and really just wants some clarification on what are her symptoms so that we can better manage. Yep, absolutely right. And in conclusion, I'll say that today we are fortunate to have a patient who has evidence of both microvascular dysfunction as well as vasospastic angina demonstrated on Coroventis and acetylcholine provocation study. And I hope that this case was of interest to all of you, and at least maybe gives you an impetus to consider functional evaluation for the patient who may not have obvious coronary artery disease. Thank you very much.
Very good.
Thank you very much, Adrian and Che-Yang, for the nice case. Thank you very much, panelists. Everyone have a good rest of a Sing Life course and a great weekend ahead. Thank you.
Thank you.